Today we are going to start the cornea part 6, and today we are going to start about the fungal keratitis. Introduction. Fungi are a group of pathogenesis. Fungi are a group of microorganisms that have a rigid walls and a distinct nucleus with multiple chromosomes containing both DNA and RNA. So as we know that a fungus has a very rigid cell wall and its nucleus contain both DNA and RNA. Fungal keratitis is rare in a temperate countries but is a major cause of visual loss in tropical and developing country. It is a very common causative organism, and a very common cause of fungus is in the developing countries and in a tropical environment, though often involving insidiously. Fungal keratitis can elicit a severe inflammatory response. Corneal perforation is common, and the outlook for the vision is frequently poor. Uh, it is saying that fungal keratitis is basically a very devastating disease because it can lead to corneal perforation. It enters into the cornea throughout, and it can lead to intact and it can invade the intact and descent membrane and endothelium, and even cause hypopion formation, and the visual outcome is usually poor after the fungal keratitis. There are two main types of fungi causing keratitis. So there is one is yeast and other is filamentous fungi. Yeast. Yeast genus Candida, a void unicellular organism that reproduce by budding, are responsible for the most cases of fungal keratitis in temperate climates. So there are two things that is saying that yeast is something that reproduce by budding. So budding is basically this is a yeast, and it produces bud, and then it separates out into two buds, and it is also causes of the fungal keratitis in a temperate climates. Filamentous fungi, for example, genera Fusarium and Aspergillus, which is very common in the developing countries, is a multicellular organism that produces tubular projection known as hyphae. They are most common pathogens in tropical climates, but are uncommon, but not uncommon in cooler region. The keratitis frequently follows an aggressive course. So, what is that? That it's divided by tubular projection known as hyphae, like this. And it is all common in a tropical climate, whereas the candida was common in a temperate climates. So, what are the predisposing factors for the fungal keratitis? The common predisposing factors include chronic ocular surface disease, the long-term use of a topical steroid, often in conjunction with a prior corneal transplantation, contact lens wear, systemic immunosuppression, and diabetes. So few are very common, like journal like chronic ocular surface disease and contact lens wear and diabetes and immunosuppression. But something that is a long-term use of topical steroid is very important. The steroid increase the development of fungi. Filamentary keratitis may be associated with trauma, often relatively minor, involving a plant matter or a gardening agriculture tool. So basically, if there is always when there is someone giving us a history of a trauma with a vegetative thing, then it is most likely to be causing because of the fungal keratitis. Next we are going to study about the candida and the filamentous keratitis. The diagnosis clinical features. So, what are the clinical features? The diagnosis is frequently delayed unless there is a high index of suspicion, and often bacterial infection will initially have been presumed. So, it first give us like it is a case of bacterial keratitis, but it is indeed a case of fungal keratitis. Clinical signs are not a definitive means of distinguishing bacterial and a fungal corneal infection. So, what we have to keep in mind that clinical signs are not a definitive diagnosis of any of the keratitis. We have to do scrapings and we have to go with the culture and sensitivity for that. Signs such as satellite infiltrate can be caused by other microorganisms as well. So, what are the symptoms? Symptoms are gradual onset of pain. So, you can say that pain is very gradually onset, it's not suddenly. And patient complain of grittiness, photophobia, blurred vision, watery or mucoplurin discharge. Now we are going to study about the different signs of candida keratitis, and filamentary keratitis. Candida keratitis is yellow white densely separative infiltrate is typical. So what is in the candida? There is a whitish lesion and it is very dense, white or yellow white. These infiltrate in the cornea. Now, how does filamentary keratitis present? Gray or yellow white stromal infiltrate with indistinct fluffy margin. So we either have a gray or yellowish white, which is very commonly seen. Stromal infiltrate with indistinct fluffy margin. Basically, it have like fluffy borders, and it is very densely yellow white. Now we can see figure 7.10a for that. This is figure 7.10a. Filamentary keratitis with a fluffy edges. So you can see that this is a keratitis and you can see that its border are very fluffy. There is a large epithelial defect and folds in the descendant membrane as well. So you can see here that there is some kind of epithelial defect and you can see the folds in the descendant membrane. Next we are going to study progressive infiltration, often with a satellite lesion. So how can we know that a fungal disease is progressing? We can see it by the satellite lesion. Basically there is a main lesion and there is a smallest type of lesions around the main lesion that is called the satellite lesion. So we can see on figure 7.10b. So this is figure 7.10b. You can see that this is some kind of main lesion and around it it is some kind of satellite lesions like here. Feathery branches like extension or ring shape infiltrate may develop. Figure 10 of 7.10c. So feathery margins is like a feather shape, like feather is like this, and you can see that feathery margins are like basically giving a branches pattern, and the branch margins are giving somewhat of a feather shape branches. So you can see here 7.10 is B is satellite lesion, C is showing a ring infiltrate with hypopion. So basically it is a ring infiltrate. D is showing a candida morphology that is stained with the coaguloflor white. We will discuss it in the coming lecture. Rapid progression with necrosis and thinning with may occur. So basically the candida, the filamentary keratitis is very first they invade the cornea and then they very move inside and then they can cause thinning and necrosis of the cornea. Penetration of an intact descendant membrane may occur and lead to endophthalmitis without any evident perforation. So it can also invade the intact descendant membrane. So it can also cause endophthalmitis as well. An epithelial defect is not invariable and is sometimes small when present. So it is sometimes we cannot see even the epithelial defect. Other features include anterior uveitis. So what can other signs of fungus keratitis? It can cause anterior uveitis, it can cause hypopion, it can cause endothelial plaque formation, raised IOP, scleritis, and sterile or infective endophthalmitis. And what are the differential diagnoses of fungal keratitis? So any kind of keratitis including bacterial, herpetic, acanthamoeba keratitis. Bacterial infection may sometimes present in a subacute fashion. So in some cases that there is a superimposed infection of there is a fungal and there is a superimposed bacterial infection as well, particularly when atypical microorganisms are responsible. It is important to be aware of co-infection including with an additional fungus species. So there are multiple fungi that can be affected or there can be fungal plus bacterial. So what are the investigations? Investigations are sample for laboratory investigation should be acquired before commencing antifungal therapy. So basically we have to get scrapings before we start antifungal therapy or any antibiotic. First we do the staining procedure. Staining is a very important, is a KOH. The potassium hydroxide KOH preparation with direct microscopic evaluation is a rapid diagnostic tool that can be highly sensitive. So what we do is we stain the scraping with KOH and then directly see under the microscope, and it is very fast and sensitive method. Gram and ginseng staining are about 50% sensitive, so we can also do gram and ginseng staining, but they are 50% stains. Other stains include periodic acid skiff, chalcofluor white, and methanamine silver. So basically chalcofluor white is something, it is a stain, and then we see it under the fluorescent light, and it fluoresces under the fluorescent light. So these grains can also be used. Other are culture. Corneal scrapes should be placed on sebarodextrose agar, although most fungi will grow on blood agar or in enrichment media. So very important culture medium for the fungi is a sebarodextrose agar. We have to remember it. It is important to obtain an effective scrape from the ulcer, but we have to maintain some effective scrape. Sensitivity testing for the antifungal agent can be performed in reference laboratory, but the relevance of these results to clinical effectiveness is uncertain. If applicable, contact lens and cases should also be sent for culture. So what can we send for culture? We can also send the contact lens cases and the contact lens itself as well. Then other method to investigate about the fungal keratitis is polymerase chain reaction, which is PCR analysis of a specimen. It is a very rapid and highly sensitivity, up to 90%, and maybe the current investigation of choice. Calcium containing swabs can inhibit polymerase activity, and local collection protocols should be ascertained prior to specimen collection. So we do not use calcium containing swab for these cases. Corneal biopsy is indicated in suspected fungal keratitis in the absence of clinical improvement after 3 to 4 days, and if no growth develop from scraping after a week. So when we do corneal biopsy, we do it if there is no growth develop from scraping after a week, or if there is no clinical improvement after 3 to 4 days. A 2 to 3 mm block should be taken similar to scleral block excision during trabeculectomy. Filamentous fungi tends to proliferate just anterior to the descent membrane, and a deep stromal specimen may be required. The excised block is sent for culture and histopathological analysis. So we tend to send the tend to take the corneal biopsy 2 to 3 mm, and we make it in the deep stromal specimen anterior to the descent membrane. Anterior chamber tap can all has been educated in resistant cases with endothelial exudate because organism may penetrate the endothelium. Confocal microscopy frequently permit identification of organism in vivo, but is not widely available outside tertiary center. So we just have to remember the names of this one. These are not very clinically used investigations. So what are the treatment that we use in the case of a fungal keratitis? Improvement may be slow in comparison to the bacterial infection. Basically, we have to treat the fungal keratitis for the longer period of time, and they are very slow responding. So what we generally do, we general measure as RS for bacterial keratitis, although hospital admission is usually required. So we tend to do the same measurement. We stop the contact lens where we admit the patient if necessary. So these are the general measures we use for it. Removal of epithelium over the lesion may enhance penetration of a fungal antifungal agent. It may also helpful to regularly remove mucus and necrotic tissue with a spatula. So some surgeons tend to what do that they scrape the epithelium so that the penetration of the antifungal agents is more good. Then, what are the topical antifungals that are used in case of fungal keratitis? Topical antifungal should initially be given orally for 48 hours, then reduced as sign permit. So, for 48 hours, we have to give it for orally. In case of candida infection, is treated with amphotericin B 0.15% or iconazole. Alternative include natamycin 5%, fluconazole 2%, clotrimazole 1%, and voriconazole 1 to 2%. So these are basically the natamycin is a readily available, whereas amphotericin we have to make it from some injections. Next is filamentous infection is treated with natamycin 5% or iconazole 1%. Alternatives are amphotericin B, basically any 0.15%, miconazole 1%, or voriconazole 1 to 2%. Basically, we can use any kind of um, uh, antifungal, but in case of filamentous, natamycin is a choice, and in case of candida, amphotericin B is the choice. A broad spectrum antibiotic might be considered to address or prevent bacterial co-infection, and we can also use antibiotic with them to if to address the bacterial infection. Cycloplegia, as for bacterial keratitis, subconj fluconazole may be used in some cases of severe cases. Now, when we use the systemic antifungal may be given in severe cases. When the lesion are near the limbus or for the suspected endophthalmitis. So, what are the indications of the systemic antifungals? If the lesion is near the limbus, then second, it is for the suspected endophthalmitis. What are the options? Options include voriconazole 400 mg twice daily for 1 day, then 200 mg twice daily. So what we give that 400 mg twice daily for 1 day, and then we give it 200 mg twice daily. Itraconazole 200 mg once daily, reduced to 100 mg once daily, or fluconazole 200 mg twice daily. Then we give tetracycline. Basically, tetracycline is given because it has an anti-collagenase effect, and it is given when there is a significant thinning. Doxycycline 100 mg twice daily may be given for its anti-collagenase effect when there is a significant thinning. Perforation or actual or impending is managed as for bacterial keratitis. We give if there is a mild, we can do BCL. If there is a medium perforation, we can use glue, and if there is a moderate, then we go for the keratoplasty. Superficial keratectomy may be effective to debulk a lesion. So what we do it, basically this is the lesion, we debulk it so that it is effective treatment. Therapeutic keratoplasty, penetrating on deep anterior lamella, is considered when medical therapy is ineffective or following perforation. So we can also remove the lesion by doing keratoplasty. We remove the cornea and we put a donor cornea into it. Anterior chamber washout with intracameral antifungal injection may be considered for unresponsive cases in which there is a stable corneal infiltrate but enlarging endothelial exudation. So we can do also anterior chamber washout if there is an endothelial exudation that is enlarging and it is not responding to the topical treatment. So that's it for the fungal keratitis. We are going to start a microsporidial. We are going to finish this in this lecture as well. Microsporidial keratitis. Microsporidial keratitis is a Microsporidia phylum Microspora are obligate intracellular single-celled parasite previously thought to be protozoa, now reclassified as fungi. Basically, Microsporidia is first thought as a case of protozoa, but now it is classified as fungi. It is phylum is Microspora. They rarely cause disease in the immunocompetent until the evidence of acquired immunodeficiency. AIDS syndrome was rarely pathogenic for humans. The most common journal infection is enteritis, and the most common ocular manifestation is keratoconjunctivitis. So it tends to affect the immunocompromised individual. And what are the systemic manifestation? It is enteritis and the infection of the intestines, and in the ocular it is a cornea and the conjunctiva that is affected, keratoconjunctivitis. So what are the signs? Signs are bilateral chronic diffuse PEC, punctate epithelial keratitis. So you can see figure 7.11a. So you can see that PEC is basically the swollen epithelial cells. So punctate so you can see the diffuse PECs are seen. So these are usually bilateral. Unilateral slowly progressive deep stromal keratitis may rarely affect immunocompetent patient, but in case of immunocompetent patient it can be unilateral, as well as it can affect the deep stromal keratitis, just like in the figure 7.11b you can see that it is a unilateral and it is very deep. Sclerokeratitis and endophthalmitis are rare. Biopsy show characteristic spores and intracellular parasite. So it is biopsy what shows. The biopsy will show us the spore and there will be intracellular parasite. Intracellular parasite. PCR of the scraping may have relatively low sensitivity. So what are the treatment? Because it is associated with AIDS, then medical therapy of the epithelial diseases with topical fumagillin. So topically it is treated with fumagillin. Highly effective antiretroviral therapy heart for associated AIDS may also help in resolution. Stromal disease is treated with a combination of a topical fumagillin and oral albendazole 400 mg once daily for 2 weeks, repeated 2 weeks later with a second course. So what we do is, in case of a stromal disease, we give topical fumagillin and oral albendazole. How oral albendazole? We give a 400 mg once daily for 2 weeks, and after 2 weeks we did repeat it for another 2 weeks. Patient should be closely monitored for hepatic toxicity. Long-term fumagillin treatment may be required, and it is difficult to eradicate the parasite in immunocompromised patient. So long-term treatment is usually required because the patient is it is difficult to eradicate the parasite. Keratoplasty may be indicated, although recurrence of the disease may occur in the graft periphery. Cryotherapy to the residual tissue may reduce the risk. So we can also do keratoplasty in this case. So that's 6 for the cornea part 6. We are going to start viral and keratitis in the next series. Thank you.